So, hi everyone. So, this is kind of a new series that me and Praveen are starting. And the idea is that because both of us work together and we have a lot of arguments while deciding what is the correct management for this patient. So, we thought it would be a good thing to share with other people and kind of discuss a lot of defined areas in ID and also gray areas in ID. So, how we thought is that we'll do like some case scenarios and we would want to know the perspective and the knowledge of uh, fresh ID physicians and including fellows. So we have with us Bharti, Ankesh, and Kirtana, who are budding ID physicians, and we'll just take them through a case. So Praveen will be the moderator. So Praveen,
Yeah,
take it ahead.
thank you. Yeah. So let us start. So this is the first case. Only we are discussing only one case, right? So this 49-year-old gentleman who is a recipient of renal allograft, live donor, 3 years back, post-transplant care was like the course was uneventful. There was no history of rejection and there was no history of any opportunistic infections. And he's on tapering doses of immunosuppression. Right now, he was on 2 milligrams of tacrolimus per day with 1 gram of MMF and 7.5 mg of prednisolone, right? So 3 months ago, he presented to the nephrology clinic with a history of redness as well as some blisters over the dorsum of left lower limb, the left leg. So at that time, it was thought, because of the appearance, it was thought that probably it is a bacterial cellulitis, and he was started on antibiotics and he was managed in a outpatient basis. However, despite of receiving antibiotics, there was no not very significant improvement. The lesions gradually increased in size. They formed a nodule-like mass, and there were some other lesions, multiple nodules, and some of these nodules got ulcerated. So this is what it was looking like when he came to us. So at this point of time, keeping the background immunosuppression, being a renal transplant recipient, looking at these lesions, what are your differentials? The first picture is the picture of left lower limb with ulcerative nodular mass. And the second picture is patient also had a similar lesion in the left upper limb, forearm. Initially, it was thought that it's lipoma, but in the past 1 month, it has significantly increased in the size. So probably this is also pathological. So with this picture, I would like to know what are the differentials you are thinking. So let's start with Bharati.
Um, so can we also get a little bit more of what is his job? Where is he from?
So he's from Karnataka. Right now, he is not involved in any farming. There are no pets at the home. He does a clerical job, right? So no significant environmental exposure, whatever we got.
And no trauma history
No
also.
trauma history in the lower limb. That was a very important history to ask.
Yeah.
So when we asked the patient about history of any trauma at the site of the lesion, he was not able to recall any history of trauma there. Yeah.
Okay. Okay. So it's a little bit a chronic ulcer almost since 3 months, I think, now with ulcerative lesions. So looks like a chronic indolent sort of infection with no fever or any other constitutional symptoms. Was not there, right, sir?
Yeah.
Constitutional. Okay.
So basically, there was no fever,
Hmm.
no cough, no breathlessness, no history of diarrhea or any joint pains.
Okay.
And there was no history of significant weight loss as well. Yeah. And the
Okay.
graft function, his creatinine is around 1.2 to 1.3
Hmm.
baseline. And that is what he was having when he presented to us. And the baseline kidney disease is a diabetic kidney disease. And his diabetes
Okay.
right now is not very uncontrolled. The HbA1c is around 6.5.
Okay.
Yeah.
So just thinking in terms of broadly in terms of organism, not in terms of most commonality. First, if you think of tuberculosis, we should keep, although there's no constitutional symptoms, cutaneous tuberculosis, I would like to keep. Similarly, cutaneous non-tubercular mycobacteria. Other than this, I would also like to think of some fungal infections, mainly dermatitis fungal infections. And also because he's having dermatitis fungal infections like phaeohyphomycosis and chromoblastomycosis, although there's no particular trauma history or history of any exposure or any like inoculation history. Other than this, because it is sort of there in and Other than this filamentous bacteria like with skin involvement, maybe like actinomycosis, nocardiosis, either. Again, for all of this, there's not too much of exposure or work-related history. Mm, common bacterial cellulitis is unlikely because it's already been treated. So I
Mhm.
think these would be part of my differentials.
Right.
So the differentials you listed out are tuberculosis, NTM, fungal ulcers,
Yes, sir.
and bacteria like nocardia, actinomycosis.
Yes, sir.
Uh, uh, Ankesh and Kitna, do you want to add any other differential diagnosis in this picture?
No, before this, uh, like first is that Bharti, these were excellent set of differentials. Exactly, these were the things that we kept in mind. One thing that you said about TB was that there was lack of constitutional symptoms. Usually,
Mm-hmm.
cutaneous TB probably would not have constitutional symptoms, so that would not rule TB out. So both TB and non-tubercular mycobacteria are very important differentials. If you want to keep a non-tubercular mycobacteria as a differential, which ones would you think?
Okay. So usually for skin and soft tissue, the rapid growers are what is most common. So maybe Mycobacterium abscessus or fortuitum or something like that, like a rapid growing mycobacterial
Right,
skin
right,
infection.
right, right. So exactly. So rapid growers like abscessus, chiloni, fortuitum,
Yeah.
uh, these would be an important differential for skin and soft tissue infections. Then you mentioned fungal infections, and you rightly mentioned demeticious fungi.
Yes,
So
sir.
both, phaeohyphomycosis, chromoblastomycosis. One thing that you mentioned was that inoculation history. Again, that is something that is very often not found. It would be some
Mm,
trivial trauma. Yes, you're right that these are
mm,
usually by implantation, but very commonly you will not get that history. So again, these are still very much possible and excellent differentials. And the last thing that you said was nocardia actinomycosis. So nocardia, cutaneous nocardiasis, post-transplantation is something that is uh, very important differential to
mm,
be kept in mind. Other thing you
mm.
mentioned was that because there was a bacterial cellulitis, it is possible that that bacterial cellulitis is related to this or might not be related to this. But
Yes, sir.
so whatever this is probably not responding to the garden variety antibacterials
Okay.
that we commonly give for cellulitis. So these are
Yes.
all excellent points. And then Praveen, sorry, take it forward.
Yeah, yeah. So as Dr. Bharti has mentioned, there are differentials are tuberculosis, NTM, probably a rapid grower, and fungal ulcers. Bharti, you want to be a little bit more specific about what fungi you are thinking about, if you are thinking fungal ulcers
Um,
with differential.
yes, sir.
One thing is demeticious. Yeah.
Domitious, Domitious fungi. Another thing would also sorry, fusariosis also I would maybe think about, but it may be presenting in a more of an acute illness with a more systemic illness, which is not there in
Mhm.
this patient. So, and other than that, mucormycosis are causing ulcer, but again, we would maybe need some usually surgical history or some trauma history for which usually it occurs after that. Other than
Mhm.
this, I can't think of any other fungal.
Right.
Yeah.
Fusariosis is an excellent differential. Post-transplantation, it could be possible. This was one of our top differentials when
Mm,
we saw the
mm,
case for the first time. Mucormycosis, and like you said, usually mucormycosis patients will be, like you mentioned, there will be possibly some implantation. Usually there are, so most cutaneous mucormycosis reports are with post-surgery, or there was some gluteal site IM injection that was given
mm,
through an unserialized needle or something, but
mm.
or post road traffic accident or something. But these are very definitely possible. So
Yeah.
great differentials again.
Excellent. So, Dr. Ankesh, so what do you think about the differentials? Do you want to add something on the top of whatever has been
Yeah.
discussed? Yeah.
So, as Bharti have discussed most of the infectious causes, most of the common, some sort of uncommon causes, I want to add some non-infectious cause
Mm,
also in such patient like uh, uh, s- uh, which can mimic such type of cellulitis like calciphylaxis, pyoderma gangrenosum, or although there is no feature, no finding like increase in the grade, etc., but maybe some sort of graft versus host disease in such patient. And in the fungal list, I want to add Exophiala and yeah, subcutaneous and the dematiaceous fungus infection that we have already discussed.
Yeah. So some other differentials which Ankesh has added, Dr. Ankesh has added, is pyoderma gangrenosum, which is a very important differential to consider because the more the surgical debridement you do, if it is pyoderma, it will keep on worsening. But most of the times we see pyoderma gangrenosum in a patients with some Th17 immune dysregulation and AML, MDS, lupus, IBD associated and reactive arthritis associated. But that is again a good differential to think about. Calciphylaxis, this patient is a post-transplant patient, so very unlikely that it could be
Like yeah,
calciphylaxis. Third differential which was added was Exophiala, which is a dematiaceous fungi, which was on the list.
on the list. Yeah.
So, keeping that, there was one more lesion in the left forearm, Dr. Ankesh. Uh, do you want to like consider any systemic infections which can get inoculated in different parts of the skin?
So can I see the picture again?
I will just go back to it. Yeah.
Right.
So
The idea here, Ankesh, is that so there are two possibilities. One, that these two are isolated different events. So there is a subcutaneous swelling in the arm, and there is this cellulitis followed by nodular ulcer, or these two are linked. It is quite possible that these two are linked. So what Praveen is trying to hint at is that there is something which is beyond an implantation infection. So there is something possibly systemic that we should also think at this stage.
Okay. So actually, as you suggested in initial part of history, this looks like lipoma, but not
yeah,
for
so
how.
initially that was the thought. Even
Yeah.
we thought it was actually looking like a lipoma and it was feeling like lipoma. But only thing was the history in the past 1 month, the size of this lesion has tremendously increased. So that was little atypical for it to be lipoma. So we thought probably it could be a part of the disease as well
Can
at
you
that
can
time.
you add some clinical findings like trans elimination, etc. part of the swelling?
It
No,
was
so
not
so
cystic.
this is not lipoma. So
Huh.
to cut short the discussion, this is not
Yeah.
lipoma, and this is associated with the skin ulcer. So
And it is not cystic. Okay.
Okay, okay.
right.
So,
So Kirtana, maybe you
Kirtana.
would want to come in at this point of time, and I agree that Bharti has made your job a little difficult by listing out every possible differential. But if you have something else in mind, maybe we can talk about that, or maybe you proceed with what is your next step that you would do. So you have seen this consult, you have seen these images, and what is the next step that you would recommend? If you don't have any other thing in mind, and then Praveen can show the differentials that we had when we saw the case.
So with respect to the multiple lesions being at multiple sites, so there is a possibility this could also, with time, maybe it was caught now progress into an ulcer, like similar to the one that is on the lower limb. So again, as Bharti said, tuberculosis can present with when there is hematogenous dissemination like this. Even maybe nocardiosis can also present like this. That puts maybe fungal ulcers and pheohyphomycosis a little, takes a step back as compared to the others, where if you consider both of these to be from the same pathology, and if you consider that the lesion might end up ulcerating similarly to the lower limb. And if the leg ulcer also started off with a swelling to start with before presenting to us like this.
Yeah. So this
Right.
picture is not very clear, but when we are seeing patients, we can actually see some of the ulcers in the other side of the leg. They were looking like satellite ulcers. So our first differential was fungal, but again we had the whole list of differentials which you have mentioned here, right? So these are the differentials which we are working with. Leishmaniasis is not common, just for the sake of completion we have added, and it could be again in a post-transplant patient there is a higher risk of skin cancers. So that was one of the differential we had. So do you want to like highlight upon any differential which you have missed, which is listed here?
Satellite lesions, maybe is schido a possibility again, schidosporium, or
sporotrichosis also. It's unlikely with the given history, but again with a transplant patient on heavy immunosuppression and presence of satellite lesions, multiple lesions
Right.
over the limbs, then sporotrichosis and maybe schizo also becomes a possible
Right,
lesion here.
right. So scedosporium goes hand in hand with fusarium. So possibly
Mm.
scedosporium is also something that we should have listed. We missed out.
Yeah.
We didn't
Yeah.
think of sporotrichosis. Uh, yes, but sporotrichosis,
And
not all sporotrichosis are that lymphangitic type. So there are
Well,
multiple possibilities. So it could be sporotrichosis also. We didn't list. One thing that you said, Bharti, which was interesting, was that you would keep pseudohypomycosis a little down the order because now that you're considering it as a systemic infection. But one thing that we can keep in mind is that disseminated pseudohypomycosis is also something that is possible. And we see that not very uncommonly. So, right, but all great differentials. If I have to now ask you to choose, each of you to choose like three top differentials based on whatever history and examination and whatever we have discussed, if you have to choose three differentials, just list your three differentials quickly and then we can move on to the what is the next step. So we'll start with Bharti.
So I think my three differentials would be fungal ulcers, more fusarium or scedosporiosis, TB, and nocardia.
Right. Kirtana?
yes, fungal with aspergillus and fusarium more than the others, and followed by tuberculosis and then nocardia.
yeah.
Right.
Ankesh, Dr.
So
Ankesh.
my top three are Aspergillus, PO, and nocardia. I mean fungal ulcers, nocardia, and NTM.
It is interesting that all three of you have kept aspergillus, but I don't know. I have never seen a skin lesion due to aspergillus. So, Praveen, what are your thoughts?
No, it is not uncommon to see aspergillus like presenting as a skin lesions. Again, sometimes patients will give the history of trauma. But again, in solid organ transplant, sometimes you see acrimonium, pheoacrimonium presenting like subcutaneous nodules ulcers. We had one case of Medicopsis romarai, which is again a type of pheohypomycosis, which can actually cause multiple subcutaneous lesions here and there.
Right.
And
If we do continue this series for a long time, you're sure to see Praveen bringing up Medicopsis romarai every episode. So for sure.
yeah.
So
So anyway, because we have these differentials in our mind, can you do some blood investigations which can give some clue about one of these diagnoses? Obviously, I know we all want to do a biopsy and send the cultures for the respective investigations. But do we have
Um,
any simple blood investigations which might give a clue about a diagnosis in your differentials?
Maybe a serum galactomannan
Yeah.
can help. Other than that, just off an off thought, I'm sure viral markers would have been HIV would have been negative and checked
Negative.
for
It is
this
negative. Yeah.
process.
Yeah.
Yeah, I think galactomannan could be one of
So
the
a
things.
little controversial thought about galactomannan. I think galactomannan is a useless test. So
Yes.
At
everybody
least
that
in
we,
our setting.
yeah,
Yeah.
at least whenever we send galactomannan, so in the two centers that I have worked,
Mm.
every time you send galactomannan for every damn patient, it comes out to be positive. So yeah, I don't think that will make any difference. Where whatever the index
Mm.
be, this is again, this is my opinion. I think this is a huge scam of a test. But any which way, so let's say that the galactomannan was negative or positive, it
It was
doesn't
sent.
matter.
It was sent. Turned out to be positive, but again, we are not very keen on the
Mm.
report of galactomannan as such. So anyway, we are going ahead with biopsy. But
Biopsy.
we but
And
we
maybe
also sent one more blood investigation, which actually gave us a
cultures,
diagnosis. A blood
cultures,
Blood
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 investigation.
cultures,
investigation, which gave us a
Yes.
diagnosis in this patient.
blood cultures in this patient, blood cultures both
Yes, you're
bacterial
right.
and
Yes, you're
fungal.
right.
Okay.
Yeah.
Yes.
Um,
Any,
Yes, sir. So not in our country, but in other Western countries like in United States. So in patient with some sort of finding with like fungal infection kind of thing, they will routinely do in culture independent manner. They will do 28S rRNA. So the test can be there. They report the test
Yeah,
in
yeah,
48
Dr.
hours.
Ankesh.
So it's kind of
Right.
Yeah, it is
very specific.
interesting, but we are a resource limited setting. But actually, I'm telling you that there was a blood investigation which we sent because of our list of differentials, and we got
Serum,
the
Serum crag.
serum
Serum
crack.
crag.
Yeah.
yeah. So serum cryptococcal antigen was sent. It is positive. So do you know, like, because the galactomannan was also positive, which I didn't mention here.
Yes.
Do you know any fungal infections which might give both serum cryptococcal antigen as well as serum galactomannan positivity? Even though in this setting we are really not considering that galactomannan whatever came positive is very significant. But to discuss, do you know any other fungal infections where both serum cryptococcal antigen and
Both.
galactomannan can be positive?
No, in Praveen's hypothetical
Like,
question, galactomannan gives positive only when it is supposed to be positive. So
Yeah.
if that is the setting, then what do
Uh,
you think would be the right answer? And again, for the future uh, videos or podcasts that we do, just in case, this is only about resource limited settings. I know Ankesh has just come back from US, so that plugins are going to come, but yeah, so only resource limited settings.
so
Um, bo-
crag
Go ahead.
positive, false
Yeah.
positive is seen with trichosporon.
yeah.
Right.
Mm.
So there are some reports of trichosporon SI in solid organ transplant patients causing skin ulcers,
Skin
presenting like
lesions.
these
Okay.
nodules. Yeah. So there are
Mm.
reports of that. And that's not a very common presentation of trichosporon SI, but there are reports. And other thing is geotrichum, right?
Geotic.
So
Usually.
basically, at this point of time, what do you want to do further?
Get a biopsy.
Biopsy.
Biopsy, and do you want anything else?
Um,
An array of tests
I
on the
mean, yeah,
biopsy,
CSF
staining.
maybe because the crack is
So
positive.
this is the biopsy. As expected, you
Mm.
are able to see some budding yeast cells.
Budding yeast.
Yeah.
Mm.
Yeah, and they are cryptococcus. Basically, this is a cryptococcus neoformans. So
Okay.
now you have a cryptococcal antigen which is positive, and the biopsy is showing the evidence of cryptococcus. Do you want to do any further investigations?
A CSF
CSF.
and maybe a
So,
lung imaging, but I don't know how that. CSF first.
so
So,
Dr. Bharati, yes, sir.
no, so I'll just add this one thing here that so serum cryptococcal antigen is something which is a very, very good test. So it
Mm.
has great specificity and sensitivity. So I'm yet to see a CNS cryptococcosis or a disseminated cryptococcosis where serum cryptococcal antigen was negative. It's a cheap test, lateral flow assay. And so if even if cryptococcus is, your 20th or 25th differential, it's worthwhile to just send it off.
Mm.
It is not going to disappoint you. So you're either going to rule in or rule out cryptococcosis. So that is something which is very, very useful.
But
Uh, yeah, you're
are
saying
the
something.
lesions necrotic like this? Aren't they more of nodular,
Yeah.
just
So
non-ulcerative?
there is no single skin manifestation of cryptococcus. It can actually cause cellulitis like picture, blisters, and it can cause nodules. Some of that can get ulcerated. So there is a no single skin manifestation which is specific for cryptococcus. It could be pleomorphic, right? So that is something to understand.
The classical description of umbilicated papules is just a classical
That is for
description.
disseminated cryptococcus
Yeah,
in HIV. That is
yeah.
how you find that umbilicated papules. But in SOT settings, you might get any picture of cryptococcus. Yeah.
Interesting.
Any idea
So
what stain this is?
Music army.
Yes, so this is a musicarmine stain, and you see that intensely stained cell
Capsule.
wall capsule,
Mm.
right?
Mm.
Sir, I have a question. So, did you biopsy the non-ulcerated lesion also?
so we
Yes,
have biopsied that also. That also turned out to be cryptococcus.
Okay.
and it grew cryptococcal. It was positive for cryptococcus culture also. So yeah, so we are sure that this is cryptococcosis. Now, what next question is that are you thinking that there is a possibility of disseminated cryptococcosis, and which are the sites that you would be interested in? And like, so there are 6 minutes left for the meeting to end. So what the question is that what are the other sites that you would be worried Cryptococcus is there, keeping in mind that this is a post-transplant patient that was on triple immunosuppression. So the patient was on TAC, MMF, and prednisolone.
So
So,
we asked the history of whether there is any headache, blurring of vision. There was
Hmm.
nothing. So patient is like completely okay CNS wise. But I agree with you. Any patient with FAG positive and two different sites of where we have isolated cryptococcus, we wanted to do an LP, but the patient didn't want to undergo
Hmm.
LP. So we did not do LP, and
Okay.
there was a question about how to investigate for the dissemination of cryptococcus. So can you tell the three most common site of cryptococcus which involves patients? Three most common
CNS, lung,
CNS lung,
CNS, lung,
skin.
lung,
And skin.
skin.
Skin. So skin is the third most common site for the
Hmm.
involvement of cryptococcus. So what is the best way of investigating the dissemination of cryptococcus in this patient? So,
Imaging.
so which imaging you want? Now we are not resource limited.
yeah, so we are a little bit of hypocrite. So
PET
here,
CT. Reading it.
Yeah.
PET
So
CT.
we got a PET CT. Yeah.
Yeah.
So besides the lesions which we are already seeing, there was again one vertebral lesion in the L5, which was enhancing. You might not be able to see that clearly in this picture.
Hmm.
so there was
So that
another
was
picture, but any which way. So the idea is that, uh, uh, so the question that I was asking is, uh, what do you think if suppose we didn't do a PET, would you expect what were your no what where would you expect Cryptococcus to be apart from skin in the backdrop that we just gave? Like,
so basically to make it little bit more simpler is the involvement of cryptococcus in a solid organ transplant patients who are on tacrolimus based immunosuppression. Is it different from the garden
Hmm.
variety of cryptococcal infections you see in HIV
right.
patients?
Do
So this is
not
the
know the
most
answer to that
interesting
question.
take home message.
Yeah, so Praveen, we don't have time, so I think
Sir,
you just give that message.
you give it, sir.
No, 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 no. Go ahead, go ahead, go ahead, go ahead.
So basically, tacrolimus has in vitro activity against Cryptococcus, but it
Oh,
inhibits the growth of Cryptococcus at higher temperatures, at 37 degrees, but not at
okay.
24 degrees. So basically, in CNS, probably tacrolimus is a good antifungal agent for Cryptococcus. But
Hmm.
when it comes to periphery, skin and bones, where the temperature is colder, so the tacrolimus might not be enough to inhibit the growth of Cryptococcus. That's why primary cutaneous Cryptococcus is a known thing in patients who are on tacrolimus-based immunosuppression, right?
Okay.
The second explanation is some of the Cryptococcus, they do have a dermatotrophism, like
Hmm.
Cryptococcus serotype D. They preferentially tend to involve the skin. But because of these reasons, it is common in organ transplant patients to have primary cutaneous cryptococcosis without involvement of CNS, right?
Yeah,
Okay.
additionally, tacrolimus is able to cross the blood-brain
Blood-brain
barrier.
barrier. So
So
that is
it
not true for cyclosporin-based regimens again.
Hmm.
So
Yeah.
therefore, when the patient did not agree to get a lumbar puncture, we were kind of okay with it because there wasn't any symptoms. It they could still be there, but theoretically, because tacrolimus has some anti-cryptococcal activity and penetrates well, and it works well at higher temperature, 37 degrees Celsius, like Praveen mentioned. So it, patients on tacrolimus tend to have these cryptococcosis on the superficial parts of the body. So basically, the patient had lesions in skin and this D12 vertebra. And eventually, uh, we ended up treating this, and the patient was doing well. But how would you treat this patient? We have
I
like 2 minutes now.
think since it's disseminated, we would still go like, okay, cutaneous disseminate. Because disseminated, we would still go with amphotericin B, maybe for 2 to 4 weeks, followed by with flucytosine, followed by fluconazole. I think I've treated same as a CNS cryptococcosis.
Right, but you would not want to draw from the HIV trials, the
Hmm.
ACTA or Ambition, because you
Hmm.
said 2 to 4 weeks of amphotericin B. So I know that there is a disparity. We'll just quickly finish this on this note. So there is a disparity between the evidence that we have for HIV and the evidence that we have for transplant patients. So in transplant patients, we follow the old evidence, whatever we have, that you give it for a 2 weeks or 4 weeks or whatever. But for HIV, we now know that 1 week of amphotericin B, if you give deoxycholate, is okay, or you can just give a single dose, 10 mg per kg. However, for this patient, we drew that equivalency, and we actually ended up giving fluconazole flucytosine based therapy for this patient because he was not willing to stay and there were resource constraints. So we treated the patient with fluconazole flucytosine based therapy, and we treated it like any other CNS streptococcosis. So thank you everyone for coming. We'll have a small
sir.
feedback after this. We will end the
Thank you.
video here. Bye.
Thank you, sir.
Thank you.
Bye.
Thank you.
Bye bye.